In the previous class, we have discussed about the physiology of female menstrual cycle, the role of different female sex hormones in conducting the different functions like the primary sexual characters, secondary sexual characters, menstrual cycle, how these are modulated. And then we have discussed about the estrogen, what is the role, physiological role of the estrogens, how estrogen can be used as a drug, what are the adverse effects of the estrogen, what are the contraindications of estrogen. Then we have discussed about the selective estrogen receptor modulator, which have some context specific agonist and antagonistic actions in different receptors in different organs. That's why these are used mostly, like tamoxifen is used in case of the breast cancer, raloxifene is used in case of the postmenopausal osteoporosis, or meloxifene is used as an hormonal contraceptive. Okay. And about the hormone replacement therapy, what are the controversies of the hormone replacement therapy and what is the current role of the hormone replacement therapy? We have discussed therapeutic uses of the estrogen. These are the ACRMs. Now starting with the anti-estrogens. So there are two anti-estrogens, Clomiphene and Fulvestrant. Of these, this Clomiphene can also be called as a part like that of the selective estrogen receptor modulator. So these compounds are distinguished from the ACRMs that they are in most of the cases, in most of the receptors, they are pure estrogen antagonists. So already we have discussed about the estrogen receptors, estrogen receptor alpha and beta is present. These drugs are basically estrogen receptor antagonists. So Clomiphene, this Clomiphene or Clomiphene citrate is mainly used for the treatment of the infertility. Now there are different causes of the infertility, we will discuss in another class. But if the infertility is caused due to the anovulation or oligo-ovulation, that is the ovulator in the menstrual cycle, the ovulation is not happening as it should be. So in those cases of the infertility, we can use the Clomiphene. Another thing is Clomiphene is also used in case of the males also to increase spermatogenesis. So in case of the male infertility also, Clomiphene can be used. Apart from this, this can be used in some cases of the short term neuralgic headache. So in these cases, we can use the Clomiphene. So this is basically a competitive antagonist of the estrogen receptor at the hypothalamus. So at the hypothalamus level, they causes the competitive inhibition. So they inhibits the negative feedback effects on the release of the gonadotropin releasing hormone. So when the gonadotropin releasing hormone is secreted, that ultimately agonizes the receptors on the pituitary and then the LH, FSH, etc. secreted. When the LH and FSH is secreted, that gives a negative feedback effect on the hypothalamus, so that there will be no more gonadotropin releasing hormone is released. So this is a feedback loop is created. But when we need more chances of the ovulation, this negative feedback effect is to be removed. So when the negative feedback effect is removed, there will be more burst of the gonadotropin releasing hormone is released. So there will be more chances of the ovulation. So they are well absorbed orally, long plasma half-life is quite long, 5 to 7 days, high plasma protein binding, undergoes enterohepatic circulation and excreted in urine and feces. So what I have discussed, from the hypothalamus, gonadotropin releasing hormone is secreted that acts on the anterior pituitary. From this, FSH and LH is secreted. FSH and LH mainly acts on the uterus and ovary. So follicles are grown. So one becomes, already we have discussed, becomes the dominant follicle. In the LH, ultimately they are mainly helps in the release of the more and more progesterone from the corpus luteum. And all these estrogen, progesterone, they also gives a negative feedback effect on the pituitary. So this negative feedback effect on the hypothalamus is mainly removed, and all the other negative feedback effects are also attenuated. So there will be more chances of the ovulation. So progesterone is the hormone that is mainly needed for the continuation of the pregnancy. So this progesterone is released from the corpus luteum, this progesterone is released from the placenta, and when there is no pregnancy, when there is no conception, so this progesterone level sharply decreased at the end of the menstrual cycle. So ultimately the menstruation starts. So we have already discussed about in the physiology. So this is the adverse effects of the clomiphene citrate, like polycystic ovarian disease, multiple pregnancy, risks of the ovarian cancer can happen because the ovaries are getting stimulated. Ovaries are getting stimulated to produce more ovum by means of the clomiphene. So there is always chances of the carcinogenesis. There is chances of the multiple pregnancy. So twins, etc. can develop. Hot flushes may develop due to antagonism of the peripheral estrogen receptor. Weight gain, reversible alopecia, blood vessel may happen. There may be some luteal phase dysfunction can also happen because we are disrupting the normal physiology. So mainly it is used in female infertility. Apart from this can also be used in male infertility in case of the in vitro fertilization, and also in some cases of the neuralgic headache it is used. So mostly how it is used in case of the anovulatory infertility, we are using clomiphene citrate for 5 days starting from the day 5 of the menstrual cycle. So usually day 1 to 4 is the menstruation, from day 5 to day 14 is the pre-ovulatory cycle, follicular cycle. So during these 5 days from day 5 to day 10, this clomiphene citrate is given and it is seen whether the ovulation is happening, etc., etc. And it is to be repeated multiple times. It is usually repeated minimum 4 to 6 months. So in every month in the pre-ovulatory cycle from day 5 to day 10, clomiphene citrate is given. And if there is no pregnancy or if there is no ovulation as such, we can increase the dose. Usually clomiphene citrate is available as 50 milligram tablet. It can be increased to 100 milligram like this. In some cases of the neuralgic headache that is not responding to other drugs, it has been seen because there are estrogen receptors in the neurons also. So this can also be blocked by means of the clomiphene, and it has been seen if we are continuing clomiphene citrate 50 milligram for 1 or 2 months, this neuralgic headache can also be decreased. Okay. So infertility due to anovulation, already we have discussed how it is used. So usually 6 cycles. If there is no pregnancy, then we have to adopt some other drug, some other means. If consumption does not happen, we have to increase the dose and etc. So clomiphene is usually combined with menotropins or human chorionic gonadotropin. So some other drugs can be combined so that there will be more chances of the ovulation, more chances of the pregnancy. If no use, there is some first degree ovarian and pituitary failure can also happen. First degree ovarian failure means there will be, even if we are stimulating the ovary, there is no chance that there will be ovulation. The ovary is, the follicles will not grow. So this is known as the first degree ovarian failure. Similarly, there may be some pituitary failure also, so that there will be no hormones. Gonadotropin releasing hormone ultimately stimulates the release of the FSH and LH. So this FSH and LH will not be released due to some problems in the pituitary. So in these cases, even if we are stimulating the ovary, there will be no ovulation. Okay. Male infertility, it can also be used in case of the male infertility, mainly due to the oligozoospermia, that is the sperm count is less, sperm count is very small. So ultimately in the similar way, they increase the gonadotropin secretion because they are inhibiting the negative feedback effect of the pituitary hormones on the hypothalamus. So this also promotes the testosterone secretion and spermatogenesis. Usually the dose that is needed in case of the male infertility is lesser in comparison to the female infertility. So 25 milligram per day for 24 days usually in a month is given with 6 days rest, and it is also continued for multiple months, usually for 6 months. To aid in vitro fertilization. So if we are to do some in vitro fertilization, again it has to be used along with the combination of the gonadotropins. Synchronous maturation of the several ova usually happens and thus improve the harvesting of the ova for in vitro fertilization. When we are stimulating the ovary, so there will be more ovum are stimulated. So in case of the in vitro fertilization, we have to choose some ovum that is, there is more chances of their fertilization. So these ovum are usually picked up and in vitro fertilization is to be done. Okay. So here is also we have to use the clomiphene citrate. Fulvestrant. Fulvestrant is another drug that is also known as the selective estrogen receptor down regulator. So basically they are down regulating the estrogen receptors. It is also a pure estrogen antagonist. It is introduced mainly for the treatment of the metastatic estrogen receptor positive breast cancer. So already we have seen tamoxifen is the drug that is used for breast cancer. The second drug that is used for breast cancer is the fulvestrant. And it is also used in case of the tamoxifen resistant breast cancer. It inhibits estrogen receptor dimerization. So for the post transcriptional modification and the response of the estrogen, there will be dimerization of the estrogen receptor when the estrogen acts on this. So when we are using this fulvestrant, this estrogen receptor dimerization is inhibited, and ultimately their interaction with DNA is prevented, and thus receptor downregulation is enhanced. Receptor downregulation means the estrogen cannot act as it should act. So ultimately it acts as an estrogen antagonist. So it is usually administered by intramuscular depot preparation. Plasma concentration reaches maximum in 7 days, and usually it is maintained for a month. Adverse effects are like hot flashes, nausea, vomiting, back pain, etc. can happen. There are some newer selective estrogen receptor modulators are also in place, like lasofoxifene. It is investigated for the treatment of the postmenopausal osteoporosis and vaginal atrophy. Osmepifene. This is similar effects on the bones like that of the raloxifene, and it does not induce the vasomotor symptoms. Another is the arjoxifene, which is again used for the treatment of the breast cancer and also to reduce the chances of the vertebral fracture by reducing the postmenopausal osteoporosis. And bajedoxifene, which is used for the prevention and treatment of the postmenopausal osteoporosis, and they have favorable effects on lipid profile. So the main selective estrogen receptor modulator now in place, now is present in the market, is the tamoxifen and raloxifene. Apart from this, ormeloxifene is present. In some of the cases, this can be used as hormonal contraceptive. Clomiphene, in some of the cases, we can also use the term as ACRM, but it is not a pure selective estrogen receptor modulator. Basically, it is a pure estrogen antagonist. Apart from, there are these newer ACRM are present, but this lasofoxifene, osmepifene and arjoxifene is not available in the market due to some adverse effects or due to some other causes. It is not present. But this bajedoxifene is present, and this can also be used for the treatment of the osteoporosis. So tamoxifen, raloxifene, ormeloxifene and bajedoxifene, these are the ACRMs. Now coming to the estrogen synthesis inhibitors. Now we are inhibiting the synthesis of the estrogen. So already we have seen that these are basically estrogens are formed by conversion from the testosterone. So testosterone is converted to the estradiol by means of the aromatase enzyme. Now this aromatase can be blocked by means of the aromatase inhibitors. So when we are using some drugs that are inhibiting this aromatase, there will be less estrogen production. So estrogen synthesis is hampered. So aromatase inhibitors can be divided into first generation aromatase inhibitor and second generation. First generation example is the aminoglutamate, lesser used nowadays, and second generation may be either steroidal or non-steroidal. Steroidal second generation aromatase inhibitor is also known as the type 1 inhibitor. This is usually causes irreversible blockade of the estrogen synthesis. Example is the Formoterol and Exemestane. Formoterol and Exemestane are steroidal type 1 irreversible estrogen synthesis inhibitors. And there are some non-steroidal or type 2 or reversible estrogen synthesis inhibitors like Anastrozole, Letrozole, Fadrozole and Vorozole. Okay. So mainly where these are used in estrogen receptor expressing breast carcinoma. Again it is used in breast carcinoma. Next is breast carcinoma which are resistant to tamoxifen. It is also used in case of the precocious puberty along with the combination of the androgen antagonist. So precocious puberty comes before the age, precocious puberty. In these cases we can also use this. And lastly, it is also used as first degree treatment of the excessive aromatase syndrome. This is another syndrome. So mainly the adverse effects of the hot flashes, joint pain and thromboembolic disease. Okay. So already we have seen, so all these hormones are mainly formed from the cholesterol. From the cholesterol, so we can see in the one path the different steroid hormones like cortisone, and different other corticosteroids are formed, and in the other arm this can be formed the androstenedione, testosterone, and from this by conversion of the aromatase estradiol in estrone can be formed. Now coming to this letrozole. Letrozole is basically an orally active type 2, already we have seen, which is a non-steroidal and irreversible blockade, causes the estrogen synthesis that inhibits the aromatization of testosterone to estrogen all over the body, indicating that within the breast cancer cells, resulting in nearly total estrogen deprivation, because they are blocking the synthesis of the estrogen from the testosterone. That's why ultimately there is near total blockade of this estrogen happens, estrogen action. So proliferation of the estrogen dependent breast carcinoma cells is suppressed to a greater extent than that with tamoxifen. So their actions are more in comparison to the tamoxifen. Letrozole is rapidly absorbed with 100% oral bioavailability, large volume of distribution, slow metabolism, and half-life is approximately 40 hours. So letrozole is basically causes type 2, this is blockade of the type 2 aromatase inhibitor. Mainly it is used in case of the tamoxifen resistant breast carcinoma. Anastrozole is another non-steroidal and reversible type 2 aromatase inhibitor. It is more potent than the letrozole and suitable for the single daily dosing. It accumulates in the body to produce peak effects after the 7 to 10 days. It is also useful as adjuvant therapy in early estrogen receptor positive breast carcinoma, as well as the palliation of the advanced cases in case of the postmenopausal cells. So letrozole, anastrozole, these are used in breast carcinoma. Exemestane. Exemestane is the type 1 or steroidal, and this causes the irreversible estrogen synthesis blockade. As a result, approximately 90% suppression of the estradiol production happens. It has some weak androgenic activity also. It has been found beneficial in early and advanced breast carcinoma. So mainly these are used in different stages of the breast carcinoma. So this is the endocrine therapy in the breast carcinoma. So if you are asked what are the drugs that can be used for the management of the breast carcinoma, so usually the selective estrogen receptor modulators like tamoxifen, Clomiphene, and in some of the cases raloxifene can also be used. Aromatase inhibitors mainly in the postmenopausal women, anastrozole, letrozole, and exemestane. Of this, anastrozole and letrozole are the type 2 reversible non-steroidal aromatase inhibitor, and exemestane is the type 1 steroidal and irreversible aromatase inhibitor. Apart from this, we can do medical or surgical oophorectomy. Usually it is done pre-menopausal patients. Selective estrogen receptor down-regulators like Fulvestrant, already we have discussed. This can also be used in tamoxifen resistant breast carcinoma. Apart from this, some progesterone, some estrogen, some androgens can also be added with this. So this is how the management of the breast carcinoma is done. Now coming to the progestins. So progestins or progestogens, this is the generic term of different types of the progestins. Okay, progesterone. Okay. So these are substances which convert the estrogen prime proliferative endometrium to secretory and maintain pregnancy in animals spread after conception. So already we have seen that progesterone release is increased from the second half of the menstrual cycle, which is also known as the secretory phase or the luteal phase of the menstrual cycle. And this progesterone is mainly released from the corpus luteum, and if there is conception, it is released from the in high amount from the placenta, and this progesterone is needed for the continuation of the pregnancy. If the progesterone level is not high during the early phases of the pregnancy, there will be abortion. And if there is no conception, at the end of the menstrual cycle, there is sudden drop of the progesterone level. And due to this sudden drop of the progesterone level, there will be menstruation. Starting of the menstruation happens. So natural progestin which is present in the body is known as the progesterone. Progesterone is the natural progestin or progestogen that is present. Now we have different types of the synthetic progestins that can also be used in different indications. So progesterone, which is a 21 carbon steroid, which is the natural progestin, and it is derived from the cholesterol. So all these are mainly derived from the cholesterol. It is secreted by the corpus luteum, already you have seen. Corpus luteum from 10 to 20 milligram per day, in the latter half of the menstrual cycle under the influence of the luteinizing hormone LH, which is secreted from the pituitary. Synthetic progestins are the number of the synthetic drugs that can be used for the treatment of the different diseases. So compounds with biological activities, they have similar actions like that of the progesterone. These are known as the synthetic progestins or the progestational agents, progestogens, progestogens, gestagens or gestogens. So these are the different terms that can be used for the progesterone or progesterone-like compounds, remember. So the progestins may be some naturally occurring hormone progesterone, already you have seen, and there are different chemical families of the synthetic progestins like pregnant series, estrone series and gonen series. Pregnant series is basically 17 acetoxyprogesterone derivatives, estrone series are the 19 not testosterone derivatives and gonen series are not gestational and related compounds. So these are according to their chemical formulations. So this is the classification of the progestins. So progestins, so this can be some C21 progestins, also known as the pregnant family. Example is the mid-deoxyprogesterone acetate, megestrol acetate and cyproterone acetate. So these are the examples of the C21 progesterone. Mid-deoxyprogesterone acetate, very commonly used, megestrol acetate and cyproterone acetate. Next, coming to the 19 not testosterone compounds. This can be again be divided into estrone series and gonen series. Estrone series example is the norethindrone acetate, ethionediol diacetate, linesterol and norethinodrel. So these are the estrogens. The most common is the norethindrone. Gonen series, within the gonen series example is the norgestrel, commonly used, levonorgestrel, very commonly used levonorgestrel, norgestimate, disogestrel and gestodene. So these are the gonen series of the progestational compounds. Apart from this, there are spironolactone like compounds like drospirenone, which also falls under this group. So these are the different types of the synthetic progestins or progestational agents that can be used in different indications. So the most commonly used of this is the mid-deoxyprogesterone acetate, megestrol, norethindrone, norgestrel and levonorgestrel and also drospirenone. So these are very commonly used. So this is the progesterone, naturally occurring progesterone in the body. This is the structure and this is the 19 not testosterone structure. So there are some side chains changes between these different groups. Okay. So progestins, about the progestins like mid-deoxyprogesterone acetate. Already I have said that this is very commonly used, and megestrol acetate. These are C21 steroids. Already you have seen C21 progestins, also known as the pregnant series, pregnant family, with their activity similar to that of the progesterone itself. Okay, because the progesterone itself is also a C21 steroid. Mid-deoxyprogesterone acetate and their micronized progesterone, they are mainly used in combination with estrogen in different menopausal hormonal therapy. So already in the previous class we have discussed in detail about the menopausal hormonal therapy or hormone replacement therapy and their pros and cons. Usually I have said that usually the estrogen is combined with some progestational agents. So this is one of the progestational agents that can be combined. Apart from this, depot mid-deoxyprogesterone acetate can be used as a long-acting injectable contraceptive. So this is an injectable contraceptive, but is a long-acting depot preparation. So it is injected and it can act for a long period of time. 19 not testosterone derivatives like estrogens, they are used mainly as a part of the combined oral contraceptives. Again, I have said during the estrogen that combined oral contraceptives usually contains a combination of the estrogen and progesterone. So this type of the 19 not testosterone compounds can be combined with the estrogens. Gonens family are another type of the 19 not family. They have diminished androgenic activity in relative to the estrogens, and they are classes of the 19 not testosterone compounds. Again, these are used in different types of the contraceptive tablets or contraceptive devices. So all these progestational agents mainly used either in case of the menopausal hormonal therapy or as part of the hormonal contraceptive. So you can see this is the activity of the different types of the synthetic progestational agents, and you can see that these progestational agents, apart from their activity on the progestational receptors, they have activity on the estrogen receptors also, they have activity on some androgen receptors also. So the different progestins have different level of the androgenic activity also, different levels of the estrogenic activity also, and accordingly we are using different progestins in different indications. For example, the first generation, different types of the like norethindrone, ethynadiol, norgestimate, norethindrone, they have more of estrogenic activity in comparison to the later generations of the progestins. So you can see they have estrogenic activity, albeit it is less, but they have some estrogenic activity. They have high progestational activity and they have some androgenic activity also. So you can see norgestrel. Norgestrel is a progestin, for example. They have no estrogenic activity. They have high progestational activity, but they have high androgenic activity also. Okay. Similarly, ethynadiol. Ethynadiol have high estrogenic activity. They have very high progestational activity, and they have minimal androgenic activity also. Second generation like levonorgestrel, they have no estrogenic activity. They have very high progestational activity. You can see 4 positive in comparison to the 2 or 3 positive, and they have 4 positive androgenic activity. So this is very high androgenic activity, very high progestational activity, this levonorgestrel. Similarly, norgestimate and disogestrel have very high progestational activity and they have some androgenic activity. While in the last generation, like spironolactone like compounds, already you have seen, like drospirenone. Drospirenone have no estrogenic activity, they have no androgenic activity, and they have minimal progestational activity. So they have progestational activity, but in some tissues they have no progestational activity, they have no androgenic activity, and they have no estrogenic activity well. So from this you can perceive that there are different progestins, synthetic progestins. So they have different actions, different estrogenic action, androgenic action, progestational action on different receptors, because these receptors are present throughout our body, not only in the gonads but also different other tissues. So what are the physiological and pharmacological actions? First is the neuroendocrine actions of the progestins, like they are produced in the luteal phase of the cycle, already we have seen. So ultimately when they are released, they decrease the frequency of the gonadotropin releasing hormone pulses, because they are giving some negative feedback effect on the hypothalamus. So GnRH pulses are decreased. This progesterone mediated decrease in GnRH pulse frequency is basically critical for suppressing the gonadotropin release, because this causes a negative feedback effect. Gonadotropin releasing hormone is less released, so gonadotropin from the pituitary is also less released. So ultimately there will be a resetting of the hypothalamic pituitary gonadal axis to transition from the luteal back to the follicular phase. That is ultimately it is a cycle. So menstrual cycle is continued. This gonadotropin releasing hormone suppression is the major mechanism of action of the progesterone containing contraceptives also. So all the contraceptives usually now contain the progesterone. So there are some combined oral contraceptive that contains both estrogen and progesterone. There are some low dose progesterone, only progesterone contraceptive also. All this basically decreases the gonadotropin releasing hormone secretion. So it is easier. So when the gonadotropin hormone releasing hormone secretion is decreased, from the pituitary FSH and LH release is also decreased. So when the FSH LH release is also decreased, so there is less chances of the ovulation. So there will be less chances of the pregnancy. So it is easy. Or in the reproductive tract, progesterone decreases the estrogen driven endometrial proliferation and leads to the development of a secretory endometrium, because this is mainly instrumental in the secretory phase of the menstrual cycle. The abrupt decline in progesterone, what I am telling. So at the end of the menstrual cycle, like in the after the day 20, 24, 20, 25, 26, there will be abrupt decrease of the progesterone level. So ultimately menstruation starts. So influences the endocervical glands, there are glands present within the cervix, and the abundant watery secretion of the estrogen stimulated structure. This is also changed to a scant viscid material. So changes in the cervical secretion also happens due to the progesterone. Very important for the maintenance of the pregnancy. Progesterone is very important. Already I have said, progesterone suppresses the menstruation and uterine contractility. So when there is pregnancy, from the placenta, from the corpus luteum, there is very high secretion of the progesterone. That's why there will be no menstruation. Because if there is high level of the progesterone, there will be no menstruation. Only if the progesterone level abruptly decrease, there will be menstruation. Okay. So the same thing already have decreased. So you can see the blue line abruptly decreased at the end of the menstrual cycle, so that the next cycle starts, and for the first 4 days we can say this is the menstruation. On the mammary glands, during pregnancy and to a minor degree during the luteal phase of the cycle, this progesterone along with estrogen brings about proliferation of the acini of the mammary gland. So basically progesterone helps in the preparation if there is some pregnancy happens. In the CNS, during a normal menstrual cycle, there will be an increase in basal body temperature. They increases the ventilatory response of the respiratory centers to carbon dioxide. There are some depressant and hypnotic actions in the CNS, possibly accounting for reports of the drowsiness after hormone administration. So there is some neurocognitive changes due to the progesterone. Okay. That's why there is some changes in the neurocognitive during the whole menstrual cycle also. Metabolic effects are also there. Progesterone itself increases the basal insulin levels and the rise in insulin after carbohydrate ingestion, but does not normally affect the glucose tolerance. They stimulates the lipoprotein lipase activity, seem to enhance fat deposition. They have reported to increase LDL, diminish the effects of the aldosterone in the renal tubule. So the different other hormones that are instrumental in maintaining the metabolic balance are also changed due to this progesterone and also due to the estrogen. There are progesterone receptors. There are 2 progesterone receptors, A and B. So they are confined mainly in the female genital tract, breast, CNS and pituitary. So it is present abundantly in the CNS, central nervous system also. So orally it is ineffective because there is high first pass metabolism. Half-life is 5 to 7 minutes. This is the normal physiological progesterone. Metabolized to the pregnant diol and excreted in urine. If we are giving some high doses preparations of the micronized progesterone, they can be used orally. The absolute bioavailability can be increased. Synthetic progestins, the synthetic ones what we have discussed, they are orally active, but not the physiological progesterone. It is also available in different types of the injections, transdermal forms, different types of the creams, etc., etc. Vaginal insert, rings, etc. So different types of the formulations. So it is where it is used. So hormone replacement therapy as combination with the estrogen. We have discussed about the menopausal hormone replacement therapy as a part of the hormonal contraceptive. We will discuss, and also used in the treatment of the dysfunctional uterine bleeding. Again, in most of the cases it is used in combination with the estrogen. Mainly it is used in the anovulatory cycle, that is the cycle is happening but ovulation is not happening. Continued estrogen action on the endometrium is the cause. So ultimately we are using the progesterone so that there will be some ovulation. Norethindrone usually stops bleeding. It is usually used in a cyclical fashion with estrogen. Progesterone with estrogenic activities is usually preferred in case of the dysfunctional uterine bleeding. So we have seen there are some progestins which have high estrogenic activity. So where we need the treatment of the dysfunctional uterine bleeding, we usually use such progestins which have some high estrogenic actions also. Endometriosis, again here it is manifested with dysmenorrhea, painful pelvic swelling and also infertility. Again we are using the treatment of the progestins. Combination of the estrogen and progestins also given. Direct action on the endometrium prevents bleeding in the ectopic sites by suppressing the menstruation. in endometriosis there is some ectopic endometrial tissues other than it should be there. So there will be some bleeding from there and there is also infertility. Here if you are using the progesterone, that can block this. So treatment for a few months, it causes the atrophy of that ectopic endometrial tissues and regression of these ectopic masses happens. So this progesterone or synthetic progestins can be used in the dysfunctional uterine bleeding for the treatment of the endometriosis. Again it can be used for the treatment of the premenstrual tensions. So during the premenstrual period, there may be some headache, irritability, fluid retention, breast tenderness, etc. There may be some depression also. So we can use in combination with some drugs. Already we have discussed about the fluoxetine or SSRI in the antidepressant class. So this selective serotonin reuptake inhibitors can also be used in composition with this. In severe cases, we can suppress the ovulation by cyclic treatment of estrogen and progesterone. So remember, in premenstrual tension, we can use the antidepressant drug like selective serotonin reuptake inhibitors like fluoxetine. We can use the combination of the estrogen and progesterone. Relatively higher doses of the progesterone is usually needed for its treatment. Apart from this, it can be used in endometrial carcinoma, palliative in advanced and metastatic cases. High doses of the progestins are needed. It can be used in threatened or habitual abortions. So there are repeated abortions are happening. So here in the first trimester, pure progesterone without any estrogenic or androgenic activity drug can be used. So threatened abortion or habitual abortion. So there are, even if there is some pregnancy, it is usually aborted spontaneously, repeated. So in these cases we can use some progesterone which are without any estrogenic or androgenic activity. It can be used in premature labor and infertility, luteal support. There may be some infertility due to some luteal dysfunction. Here we can also use this progesterone. So these are the different indications of the progesterone. Okay. So these are all the indications of progesterone. You can see hormone replacement therapy as a part of the hormonal contraceptive in dysfunctional uterine bleeding, in endometriosis, in premenstrual tension, in case of the endometrial carcinoma also as a palliative therapy, threatened or habitual abortion and premature labor and infertility. Okay. Adverse effect of the progesterone, there may be some breast engorgement, fever, headache can happen, fluid retention, depression, irritability, acne, weight gain, onset of the diabetes can happen, decreased libido, irregular menstrual cycle, thromboembolism, atherogenesis, masculinization, some congenital abnormalities if the progesterone is given when there is already pregnancy. As a part of the hormone replacement therapy, already we have seen that hormone replacement therapy, there may be chances of the breast carcinoma also. So there are different types of the adverse effects are also there with progesterone. Now coming to the antiprogesterone, Mifepristone. So Mifepristone is a derivative of the 19 non-progesterone norethindrone containing a dimethyl aminophenol substituent at the 11th position. So basically there are some substitution change that usually causes some antiprogesterone. But this antiprogesterone also have some anti-glucocorticoid action also. So Mifepristone acts as an antagonist to the progesterone receptor as well as the glucocorticoid receptors. It was initially thought to be a pure antiprogesterone, but now it is considered a progesterone receptor modulator. Again, it basically modulates the progesterone receptors in different organs. It acts primarily as a competitive receptor antagonist for both progesterone receptors, although it may have some agonist activity in certain contexts. Okay. So, pharmacological action, when the Mifepristone is given in the early stages of the pregnancy, it causes some decidual breakdown by blockade of the uterine progesterone receptors. So, already we have seen progesterone is needed for the maintenance of the pregnancy. So, when we are using some antiprogesterone, so basically where it can be used? So, it can be used as an abortifacient agent, that is for abortion in case of the unintended pregnancy. So, ultimately when these are used, they are blocking the progesterone receptor. So, ultimately there will be some decidual breakdown in the endometrium. This leads to the detachment of the blastocyst. That is the blastocyst, the embryo that is already being implanted within the uterine endometrium due to the breakdown of the deciduum, due to no progesterone support, due to the blockade of the progesterone by means of the mifepristone, the blastocyst will be detached. Okay. So, which decreases the human chorionic gonadotropin production. So, human chorionic gonadotropin is also needed for the sustenance of the pregnancy. So, this HCG level is also drops. So, in turn it causes a decrease in progesterone secretion from the corpus luteum also. So, basically the progesterone that is secreted from the corpus luteum, that is also decreased. So, all this further accentuates the decidual breakdown. Okay. So, decreased endogenous progesterone. So, endogenous progesterone, that is the progesterone already present in the body, this cannot act due to the presence of the mifepristone, plus blockade of the progesterone receptors of the uterus, plus there is less release of the progesterone from the corpus luteum. All this leads to uterine increased prostaglandin level and ultimately sensitizes the myometrium to their contractile action. So, myometrium becomes more contractile because there is no progesterone support. The blastocyst is already detached. It also causes cervical softening. Cervix becomes softened and all this facilitates expulsion of the detached blastocyst. So, there will be abortion. Expulsion of the detached blastocyst happens. So, apart from this, it can also delay or prevent ovulation depending on the timing and the manner of the administration. So, when we are giving. It also binds glucocorticoid and androgen receptors and exerts the anti-glucocorticoid and anti-androgenic actions. Okay. Thus, mifepristone blocks the feedback inhibition by cortisol or ACTH secretion from the pituitary. So, it increases the plasma levels of the corticotropin and adrenal steroids also. So, all this how the abortifacient action of the mifepristone happens, it is clear. So, these are the steps by which it happens. So, mainly it is used, where it is used? So, termination of pregnancy for the abortion up to 7 weeks. So, usually 600 milligram as a single oral dose causes complete abortion in 60 to 85% of the cases. So, mainly this is used for the medical termination of the pregnancy. To improve the success rate, so you can see the success rate is 60 to 85%. So, we can combine another drug to increase the success rate of the abortion. So, current recommendation is to follow it up with after 48 hours with 400 milligram oral dose of the Misoprostol. So, Misoprostol further increases this. So, first we are giving some 600 milligram of the mifepristone, after 48 hours we are using the Misoprostol. Okay. So, this achieves greater than 90% success rate and is the accepted non-surgical method of early first trimester abortion. So, early first trimester up to usually 7 weeks, now the guideline says it can be done up to 10 weeks. 10 weeks of the pregnancy, 7 to 10 weeks of the pregnancy, early first trimester abortion, we can use the mifepristone, which is an anti-progestational agent, and further it has some anti-glucocorticoid actions also. Usually it should be followed 48 hours with some misoprostol. If administered within 10 days of the missed period, it usually results in heavy period, heavy menses. It is not effective after 7 weeks, usually 7 to 10 weeks. Because later placenta starts secreting enough progesterone to overcome the anti-progesterone effect of the mifepristone. So, usually the progesterone release from the different this placenta corpus luteum increasing. Okay. So, if we are using this mifepristone usually after 7 weeks or 7 to 10 weeks, there will be so much progesterone, mifepristone cannot block all. So, there the chances will be all very meager. It can be used as a postcoital contraceptive also. So, mifepristone can be used within 72 hours of the sexual intercourse. It interferes with implantation. Okay. In the emergency contraceptive, we will also discuss, and it is usually effective method for emergency contraception. Softening of the cervix, already we have seen mifepristone causes the softening of the cervix prior to surgical abortion, and also for the labor induction. For induction of the labor, in case of the intrauterine fetal death, that is within the uterus the death of the fetus happens due to some reason. This is known as the IUFD, intrauterine fetal death. Now we have to expulse the fetus. So again we have to use the Mifepristone. Endometriosis, we can use uterine fibroids, we can use progesterone dependent brain neoplasm, meningioma. So in case of the brain cancer, brain neoplasm, brain cancer, there already we have seen that progesterone receptors are present in the CNS. So progesterone receptor positive brain carcinoma, meningioma, we can use this Mifepristone. Uterine fibroids, we can use. Progesterone dependent breast cancer, Cushing syndrome is another syndrome because it is also blocking the glucocorticoid receptor. So this is palliative due to glucocorticoid receptor blocking property, may be used for inoperable cases. So in Cushing syndrome, due to some tumor, there will be more release of the corticosteroids. So here we can use this Mifepristone also for blockade of the corticosteroid receptors as a palliative therapy. Ultimate treatment is the removal of the tumor that causes the more release of the corticosteroids. Side effects are abortion failure, of course, it is not 100%. Prolonged bleeding can happen, abdominal cramps can happen, vomiting, diarrhea, anorexia can happen. So all this can happen. So this is about the Mifepristone. Ulipristal. Ulipristal is a derivative of the 19-not-progesterone. It is basically functions as a selective progesterone receptor modulator, SPRM. Unlike Mifepristone, Ulipristal appears to be relatively weak glucocorticoid receptor antagonist. In high doses, they have anti-proliferative effects on the uterus. Mainly, it is mainly used to inhibit the ovulation. So mainly they have anti-ovulatory effects. So causes inhibition of the LH release through the hypothalamus and pituitary and inhibition of the LH induced follicular rupture. Again, this Ulipristal can also be used as an emergency contraceptive. So Ulipristal is basically a selective progesterone receptor modulator that can be used as an emergency contraceptive. There are some newer progesterone receptor modulator are also there, like there are some Onapristone. Onapristone is another modulator. It is a pure receptor antagonist. Another is the Asopristone. So basically these are used in different types of the cancers, different types of the progesterone receptor cancers or neoplasms. This has been used. Okay. So just remember the name Onapristone, Asopristone, and different other agents are also there which are different progesterone receptor modulator. Next, coming to the hormonal contraceptives. So contraception means there is some intervention to decrease the chances of the pregnancy. So these are the hormonal preparations used for the reversible suppression of fertility. So usually the motto is the reversible. So if again the patient wants to do some pregnancy, then if it can be stopped so that the pregnancy can happen. So it should be reversible, that is the thing. So in India, contraceptive prevalence is approximately 48%. So ultimately there will be more and more unwanted pregnancies and also maternal deaths if the contraceptive advice is not followed. So contraception means interception in the birth process at any stage ranging from ovulation to ovum implantation. So we can block the ovulation, we can block after ovulation, we can block the implantation. So in the different stages we can block, okay, by means of the contraceptive devices. Usually we will discuss today about the oral contraceptive pills which are taken usually orally and ultimately prevents pregnancy. So oral contraceptive pills usually of two types. One is the, already we have seen, one is the combined oral contraceptive pills. Already we have discussed combined means combination of estrogen and progesterone. And another is the progesterone only pills, POPs. Of this, the combined oral contraceptive pills is very much effective in comparison to the progesterone only pills. Okay. So this is the most frequently used agents containing estrogen and progesterone. Efficacy, we can say theoretical efficacy is 99.9%. Okay. But for the progesterone only contraception, the theoretical efficacy is the 99%. This is lesser. Combination, this combination can be monophasic, biphasic and triphasic. We will coming this. Usually this is given as a tablet which is a 21-day pack and 7 days gap. Usually the gap are, within this gap usually some placebo or some iron pills are given so that there will be continuation of the taking of the contraceptive pills. Okay. So usually it is given in 21-day pack. Virtually all preparations come as a 28-day packs with the pills for the last 7 days. Usually some inert ingredients, usually some iron tablets are given. Because otherwise, if only the 21 days given, there may be some missed. So combined oral contraception, estrogen and progesterone is given. What estrogens are usually given? Usually the ethinyl estradiol is given, which is 20 times more active than the normal estrogen present in the body. Now the previous contraceptive pills contain high doses of the estrogen, and different trials have shown that if we are decreasing the estrogen level, that also causes a very effective contraception with minimal adverse effect. So already we have seen there are numerous adverse effects of the estrogen in the previous class, like thromboembolism, stroke, etc., etc. So if it has been seen that if we are using even if very less, like 20 microgram or 30 microgram or 35 microgram, that is also causes very effective contraception. So these are known as the low dose pills, low dose combined oral contraceptive pills. Okay. Usually these high dose are not used nowadays. Mestranol can also be used. And within the progesterone, these compounds can be used like norethindrone, levonorgestrel, gestodene, desogestrel, norgestimate, etc. or drospirenone. All this we have shown at the different types of the progestins, different types of the synthetic progestins. So ethinyl estradiol most commonly, or mestranol plus any of these. So this is the combined oral contraceptive pills. So monophasic, biphasic and triphasic. Monophasic means each tablet contains a fixed amount of estrogen, fixed amount of the progesterone. It is to be continued for the 21 days of the cycle. Biphasic means each contains a fixed amount of the estrogen, but the amount of the progesterone usually increases in the second half of the cycle. That is the strip usually contains, usually in the strip it is written as day 1, day 2, day 3, day 4 like this. The patient have to take day 1 tablet, day 2 tablet like this. So in the biphasic pill, in the latter part, the progesterone agents, there will be changes like that mimics the normal physiological release of the progesterone. Triphasic means the amount of the estrogen may also be variable, and the amount of the progesterone is changed in the 3 equal phases. That is, more and more it is mimicking the physiological changes in the estrogen and progesterone level. So this is the difference between the monophasic, biphasic and triphasic pills. So it has been possible to reduce the amount of the estrogen. Already I have said that with very minimal doses of the estrogen, like 20 microgram to 30 microgram or 35 microgram, it can be able to do contraception. Third generation pills, now it is known as the third generation pills that contains very minute amount of the estrogen. Ethinyl estradiol 30 microgram daily is considered threshold, but it can be reduced to 20 microgram per day also. Already you have seen the progesterone 19 not testosterone is usually combined, which has some potent anti-ovulatory actions also. So they have actions at the different levels of the cycle. So the estrogen content already we have seen, usually 20 to 50 microgram. Preparations contain less than 35 microgram are known as the low dose or modern pills. I have discussed. The combined pill is to be taken for 21 consecutive days, followed by the 7 pill-free period, which causes the withdrawal bleeding. Okay. Normal cycles of the menstruation usually commence fairly soon after discontinuing the treatment. So the triphasic pills, like already we have discussed, like in the first 6 tablets, you can see contains 50 microgram of levonorgestrel and 30 microgram of ethinyl estradiol. The next 5 tablets contains 75 microgram levonorgestrel, 40 microgram ethinyl estradiol. And the last 10 tablets contain 125 microgram levonorgestrel and 30 microgram ethinyl estradiol. So you can say there are changes. So estrogen and progesterone doses vary over the course of the cycle. Minimal doses in the first half of the cycle of the contraceptive purpose, and the maximum doses given in the latter part of the cycle to prevent the breakthrough bleeding. So what are the advantages? It minimizes the undesirable effects on the lipid profiles without compromising the contraceptive efficacy. So lastly, how this combined oral contraceptive acts, already we have discussed in the different levels. So mainly the estrogen, when we are using the estrogen, that inhibits the secretion of the FSH via the negative feedback effect on the anterior pituitary. So again the negative feedback effect, So thus suppresses the development of the ovarian follicle. So ovarian follicle will not become the dominant follicle. Progesterone inhibits the secretion of the LH and thus prevents the ovulation, and it makes the cervical mucus less suitable for the passage of the sperm. Okay. Estrogen and progesterone also acts in concert to alter the endometrium in such a way to discourage the implantation. So even if there is ovulation happens, even if there is fertilization happens, there will be discouragement in the implantation. So in the different steps, there will be checks when we are using the combined oral contraceptive. So even if one escapes, in the next step that can be blocked. The mechanism is like that. So this may also interfere with the coordinated contractions of the cervix, uterus and fallopian tubes that facilitate the fertilization and implantation. So the fertilization and implantation needs the coordinated contraction of all these things. All these also can be impaired. So the common adverse effects, what are the common adverse effects? Weight gain owing to the fluid retention or an anabolic effect. There may be mild nausea, flushing, dizziness, depression or irritability. There may be some skin changes like acne or increase in pigmentation, amenorrhea, variable duration on cessation of the taking the pill. So this can happen. So this is the combined oral contraceptive pill. In the next class, we will discuss about the contraindications of the contraceptive pills. We will discuss about the progesterone only pills. We will discuss about the emergency contraception and the different other contraceptive devices that uses the hormones. Okay. And next we will discuss about the androgens. So thank you.